I want to thank everybody coming out today on this Father's Day weekend. I know we have a lot of things we'd like to do. I do appreciate you taking time to come out here for our support group and for us listening to our speaker today, Dr. Vescio. My name is Anthony Seibert. I'm co-chair of the Inland Empire Multiple Myeloma Support Group, co-chair along with Tom Corbett. Unfortunately, he will not be here today. I have some troubling news. On the way here, he is back in the hospital. He has another infection. It is not pneumonia. I don't have any more information other than that, but I will get more and I will update you before the end of our meeting today. So keep him in your prayers, as we always will. We will get through this. So, unfortunate. Before we get to Dr. Vescio, I just want to talk a little bit quickly about some important things that are happening on the legislative front in this state. In your packets, you'll see my ugly mug. And I don't usually like to toot my horn. I just have it in there because of the fact that, not to say, oh, you're advocate of the month. No, the thing is, I'm trying to stress the importance of getting this bill passed, AB 1000, it's the Oral Chemo Parity Act, that has passed the Assembly. It is now in the Senate Health Committee, being considered there. There will be a hearing on it on June 27th. It's very important. As we all know, the disparity of intravenous medication versus oral chemo. I have sent to everyone that's on my email list this thing to get on there and send an automatic message to your legislator. I have a laptop set up for those who have not done so. It's very easy. We can log you in. It's automatic. It can be done, and boom, it routes it to your legislator. So I'm really pushing this. They want to push this as well. The word is that the Senate Committee Chairman is against this bill and possibly wants to kill it before it would even get out of committee to be voted on the Senate floor. I have another flyer that the Iemmsg just came out with yesterday and sent it to me that they want people to call, and I will be passing this out personally, as a script, and they want you to call and influence the senator to get this bill considered and out of committee. If it doesn't go out of committee, then that's it. It's over. So this is very, very important. That's why I'm taking time out to stress this. Okay. I want to give some credit. Excuse me. I want to give some credit to the people who make this happen, and I want them to stand. First of all, I want to give credit to our steering committee. First off, Big Jack Russell on video. His lovely wife, Carrie, at the registration table. And our own bundle of energy, Monica Hernandez, right there. And last but not least, my beautiful and lovely wife, Denise. Thank you. Also want to give credit to my son, Anthony Jr., who's helped out with setup today. Anthony, take a stand. Okay. Let's recognize the sponsorship of our lunches. Again, we're grateful that we are able to have premium lunches, again, for our meeting, without which, this would be a regular meeting with coffee, tea, I want to thank Laura Adams of Millennium. Laura, would you please stand? And we will also have sponsorship for lunches in our August meeting when we have another good speaker. So, I know we're getting spoiled. There are going to be some meetings where you're just going to have that coffee, tea, and that's it. So, all right. Oh, and I also want to recognize the Cancer Center here at Riverside Community Hospital. They sponsor the water, the soda, and so forth that we get, and I want to recognize them. Okay, let's get to something that I really like, and that's Father's Day appreciation, right? As I said in the newsletter, said it wouldn't be proper for us to have a meeting on the same weekend, including Father's Day, without giving tribute to all the fathers in the group. And that's what I'm going to do, because you fathers, as the mothers, you make it happen. You help us. Whatever we need stuff to do, you come in, you pitch in. So we wanted to recognize you. And that's what we will do right now with these gifts that I want to hand out. So may I please ask that our steering committee members please come up to the front. Jack, you can stay there because you got to film this. Anthony, you want to come up with your mug for your mother? That's right, nobody knows. Now, can I ask all the fathers to please stand up?
I have a lot of them.
Okay. Okay. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 12.
Thank you.
All right, well, thank you so much for inviting me out here today. It's a nice day, and what I'm going to do, it's nice to see a lot of familiar faces. So what I'm going to do is give a little bit of an overview of multiple myeloma. I know there's kind of variability on how much people know about the disease. Some people are, old hands at this and know all the particulars, and others not as much. So I'm going to try to give a little bit of an overview, and then as we go along, I'll talk about all the drugs that are used for multiple myeloma and kind of the reasoning behind it. I'll throw in a little bit of my own little thoughts about how to treat people with multiple myeloma. We all have our general biases just from our own experiences and our own way of interpreting the information. And there's not always a right or wrong answer. It's kind of, although some people believe there will be, but there's Republicans and Democrats, so there's people on both sides. So you get different opinions depending on who your doctor is, and it would depend on your own circumstances on how best what best treatment would be the right one for you. And then I'll talk about finally at the end some of the new drugs, and that's what's I think most promising is there's a lot of new drugs that are in the pipeline. Some I think will be available shortly. Some are in trials, and that's the key, is to have not only figure out how best to use the old medication, the medication that's already available, but to have new medications coming along so that they can outpace the disease. And I have patients who've had this disease more than a decade, and they're, by the time their disease starts to progress again, then there's 2 new drugs that are out there for them to try. So that's, I think, the key is the research and coming up with new things. So, and then, I'll try to just give my little more of my didactic, lecture and go through things. And then, as you heard, after or during lunch and after lunch, it'll be open for questions. A lot of times that's the most useful part of the whole meeting, is just, having other people kind of understand what you're going through, and a lot of times the questions that you ask, other people are curious about the same thing, so I'll do my best to answer everything. So I work at Cedars-Sinai and really just take care of patients well, exclusively take care of patients with multiple myeloma and amyloidosis. It's like there's always these computers. And amyloidosis, which is a related type of condition, which I'll talk about briefly. But multiple myeloma itself is, most people never heard of the disease when they get, diagnosed as having it. So it's kind of a shock, like what is this? But it's not rare. It is 20,000 people nowadays develop multiple myeloma every year in this country. And more people are living with multiple myeloma, and in a weird way, that's a good thing, because if people get diagnosed and can live with it, the numbers that are living with multiple myeloma go up. So the longer people can keep the disease under control. Almost always, when people first find out that they have multiple myeloma, understandably, one of the first questions that happens is, why me? Why did I get this disease? What was it that made it happen to me and not somebody else? And I have a patient who kind of looked at it the other way. Why not me? Unfortunately, I mean, it can be, and it can happen in anyone. What generally causes multiple myeloma is a mistake in one cell in the DNA, and usually there has to be more than one mistake. There's numerous mistakes, and it happens in a plasma cell, which I'll go through. And so things that might stimulate those cells to replicate and divide more aggressively, more frequently, may make it, and probably do make it, more likely to get multiple myeloma. So things that stimulate plasma cells to grow are things like infections, things like autoimmune diseases. So autoimmune diseases are I'm sure you maybe have heard of people with lupus. Have you ever heard of this SLE, or it's called lupus, or rheumatoid arthritis? And there's other diseases that people see rheumatologists for, that those conditions stimulate the immune system, and just by doing that stimulate plasma cells to divide, and the more they divide, the more likely a mistake can happen. So that's probably the short answer for how multiple myeloma develops. There is a small genetic component to multiple myeloma, so there are some families where, mother and daughter, or two family members have multiple myeloma. I once met identical twins, both of them having multiple myeloma. It does become more common as you get older, so it's pretty rare for people under 30 years of age, but it occasionally happens, and I've seen people even less than 20 years of age with multiple myeloma. It's a little more common in men than women. Nobody's sure why that is. And then it's twice as common in both men and women in people that are African Americans. And again, nobody's really sure why that happens. So this just kind of shows you a small print down there, but this shows you kind of how the incidence goes up as people get older. So it's pretty uncommon in 30-year-olds, 35-year-olds to get multiple myeloma, but it occasionally can happen. But most people that develop this disease are in their 60s and 70s and even 80s. So a myeloma cell is this purple-looking cell. That's the cancer cell. That's the one we're trying to get rid of with the treatment. And this is a sample, a smear of a bone marrow. And pretty much everybody that has multiple myeloma has had a bone marrow biopsy to prove it. And the reason we do that is to take the fluid out of the bone marrow, put it on a slide, and see what cells are in there. And the reason, I can instantly know something's wrong is because that I know is a plasma cell, and you should only have out of about 100 cells in the bone marrow, only about 1 out of 100, maybe 2 or 3 out of 100 should be a plasma cell. And yet, these red ones don't count. Those are red blood cells that carry oxygen. So all the ones with a nucleus that I can see in this slide are plasma cells. And so instead of it being 1 or 2%, it's, 100%. And so that's what tells somebody that they have multiple myeloma. However, the weird thing about the disease is if I were to just show, specialists and pathologists that cell, that one cell that I circled, they could not tell that that's a cancer cell. That looks like a normal cell. So what makes it cancerous is the fact that there must be a cancer because there's way too many of them. And nothing else would do that. So multiple myeloma is a cancer of plasma cells. What are plasma cells? Plasma cells are developed from lymphocytes. So your body has stem cells, blood stem cells, that regrow the bone marrow. And as a cell, and the way cells grow is one cell multiplies by splitting into two. And one cell, when that happens, one cell just kind of stays and does what stays a stem cell, and the other one turns in and matures into a white blood cell or a red blood cell, a lymphocyte, or a megakaryocyte, which makes platelets. So if it turns into a lymphoid cell, the cell goes to the lymph node and it just sits there waiting to see if you get exposed to a virus. And then if you do, that cell gets a signal like, whoa, we're useful. And then it turns into, it leaves the lymphocyte, goes to the bone marrow, and turns into this plasma cell. And the main function of a plasma cell is to make antibodies, or immunoglobulins. I don't know why there's two names for the same thing. Antibodies, immunoglobulins, the same thing. And those are the proteins that these cells make to help you fight infection. If you don't have antibodies, you're much more likely to get infections like pneumonia, like sinus infections. So we need plasma cells. It helps to have plasma cells to protect us from infection. So what happens is one of those plasma cells, and we should have millions of different ones in our body, gets something wrong with its genes, and instead of it just dying off, it now just grows without control. And your body everything's in balance, so to have one thing kind of grow out of control, that can cause problems. We all need, say, even muscle cells, but to have them grow continuously, that wouldn't be good. The bones, everything. So there has to be a limit to how much those cells multiply, and that's what happens in a cancer. Is the limit is lost. This is probably hard to see, but other diseases I'm sure you've heard about, like leukemia. So what's leukemia caused by? Well, that's if one of those actual stem cells, if the stem cell itself gets a genetic mistake and becomes cancerous, when it's a stem cell, then you have a bunch of stem cells in the bone marrow, and that's leukemia. So little kids, sometimes older adults, they get leukemia. If the cell goes to the lymphocyte, like I mentioned, and it's a lymphoid cell, and it goes into the lymph node, and while it's in there, the genes get messed up and it becomes a cancer cell. Those are where all the lymphomas come from, because the cell's in the lymph node. So people with lymphoma get cells that like to stay in the lymph node, but now they're replicating, and one of those cells and that's why these the lymph glands get all enlarged. And then if the cell leaves the lymph node, and goes into the bone marrow, and then becomes cancerous, that's where multiple myeloma comes along. So that's how, a lot of times when we find drugs that work for lymphoma, they often have a good chance of working for multiple myeloma because they're kind of related. It's a lot plasma cells kind of comes from a lymphocyte. Most people with multiple myeloma have symptoms, but actually some people have no symptoms. You can have, it's kind of an unusual thing. You can have a cancer and feel fine, but I see quite a few people like that. And sometimes people go in for a routine checkup. Their proteins are measured in their blood, and they notice their protein is really high in their blood, and then something else is done, and they do an SPEP, and then a bone marrow shows they have multiple myeloma, but they feel well. And so far, those patients are just watched. But most people do have symptoms, and the symptoms people often have when they find out about multiple myeloma is pain, because the myeloma cells can injure the bones, and they weaken the bones, and it's kind of like a toothache. If you have a cavity or an infection in the tooth, it just aches. Till you get rid of it, then that's the symptom. Same thing in the bones. If the myeloma cells are in there causing damage, it causes just kind of an achy pain. It can also weaken the bone, and then the bones can break. So obviously something we want to avoid. Infections, because the body's immune system is suppressed. People with multiple myeloma at diagnosis, they're not making the normal antibodies you need to fight infection. So you get infections, and that's constantly one of the problems people with multiple myeloma face. Anemia, because your myeloma cells are in the bone marrow, and when I showed you that picture of that plasma cell, there were no red blood cell making cells in there, where there should be. 1 out of 4 cells should be a red blood cell making cell, but there were none. So if you don't make any red blood cells, eventually the old ones, the ones that are made, die off, and you become anemic. And if you're anemic, you're tired. And then kidney damage, because the protein that the myeloma cells make can hurt the kidneys. So what can happen is when those myeloma cells grow, they can cause these holes or lytic lesions in the bones. They weaken, and in this case, it's when the myeloma grows like in clumps. So presumably, at one point, this person had a whole bunch of multiple myeloma there, and it obviously dissolved the bone in that person's skull, which looks bad, but it's hard to break your skull. So if I was going to choose a place to get the multiple myeloma or have it weaken my bones, I would kind of rather have it in my skull than right down here in my arm, where we can weaken it and potentially cause a problem, make it break. The thing about it is, once you kill the myeloma cells and put somebody in remission where the myeloma is controlled, those holes don't usually go away. It's like termites in the wall. You have termites, they eat the wood, they leave kind of a hole there. Even if you fix the termites and they're gone, the wood's not going to repair itself fully. So it's the same with the bones. So the key is to prevent that from happening and get rid of the myeloma cells as quickly as possible. So how do we figure out somebody has multiple myeloma? Well, we look where the myeloma is in the bone marrow. I mean, nobody likes to have those bone marrow biopsies, but that's where the cells are made, so that's why we have to get a sample of it at certainly at diagnosis and often later on in the course of treatment. We also measure the protein that those cells make. Since nobody wants to have those bone marrow biopsies every month to see if how the multiple myeloma is doing, instead we can get around that by measuring what's being produced. Measure the protein that the cancer cells make. So that way, if that protein that the cancer cells make is going down, there must be less of those cancer cells in the bone marrow making the protein. So we use that as a surrogate, as a way of identifying what's happening inside the bone marrow. And then we look at the bones to see if the bones are being damaged, to see how the multiple myeloma is doing as well. Not everybody has problems with, some people the myeloma cells are there, but they don't make thin the bones. So this is what, if you blew it up a billion times, this is what an antibody protein would look like. It looks kind of like a Y. It's made up of two parts. This longer piece is the heavy chain, and the shorter piece is the light chain. And the part in yellow, in an IgA, and there's two of each to make one antibody. The part in yellow is the constant region. All IgA proteins, this part of the protein would be the same. All kappa light chains would have the same thing here. All lambda light chains would be different, but the same. All lambdas will be the same here. What changes is the part in blue. That's what tells. It's like the teeth of the protein. That's what tells what the antibody is made to. Whether it's made to a mumps virus or a staphylococcal bacteria or a fungi or something innocuous. That's what the antibody. That tells us what the antibody is made to. And you need the whole piece in order for it to be effective. Now there is a precursor, kind of precursor to multiple myeloma. It's called Iemmsg. Kind of a terrible name, but nobody's come up with a better one. So it's monoclonal for one clone, gammopathy, which is for protein abnormality. So one clone protein abnormality, and I don't need to tell you what unknown significance means. So most of the time people figure this out when they get a blood test. And somebody looks, says, well, maybe, their protein's high, they get a blood test, and then find out that they have this. Most people with multiple myeloma, if you were to look back and take a blood specimen 2 years before you were diagnosed, sometimes even 10 years before you were diagnosed, this would have been there. So people wonder whether we should just randomly screen everybody for this problem. That it kind of intuitively sounds like we should, but often when you make the diagnosis, you have to do bone marrow biopsies. Many people will never changes to multiple myeloma, and at the moment, finding it early doesn't necessarily lead to doing something right away. But maybe in the future, that's what we'll be doing, is screening the population just like we do for colon cancer with colonoscopies and breast cancer with mammograms. There is a condition, and I don't want to scare people, and because it's probably people in the room that have had this multiple myeloma long enough, and nobody's mentioned this, don't have this, but there is a condition called amyloidosis that's related to multiple myeloma. And what happens there is the antibody protein fragment, the light chain part of it, builds up in the tissues. So it's, normally you hear about drinking fluids to kind of get rid of that protein, and you got to keep drinking water so you don't hurt your kidneys. Well, in people with amyloidosis, the protein builds up in their kidneys instead of passing out in their urine so much. And it builds up in their heart. And I saw a gentleman, Wednesday, where it's built up into his heart enough where, he's an extremely fit guy, but can barely walk to the front door because his heart is full of this kappa light chains in his case. And it makes his heart stiff and not work right. So the key is to kill the cells making the protein, and that's what he's in the process of doing. The treatment's kind of the same, actually. So this is the staging system for multiple myeloma, at least as of now. There's two tests. One's the kind of abbreviated beta-2 microglobulin, and the other is albumin. This is only useful really at diagnosis. And frankly, I don't personally find it that useful to help decide what to do. It's helpful if you compare one study done here to a study done in Italy, And you can say, well, you know, some people would argue, well, all those Italian patients, they were all nice and healthy. The people out here in Riverside in the study were not so much, and that's why, you know, the Italian people did better, or vice versa. And then you could look back and say, well, no, if we look at how many patients were in stage 1, stage 2, and stage 3, they were about the same, and so no, there really wasn't really much of a difference between the two groups. But for each person, I don't find it that helpful, because ultimately, no matter what stage, you have to treat the disease and get rid of it. I think sometimes this can be confusing about these chromosomal tests, but if there is a cancer cell, if somebody has cancer with multiple myeloma, there has to be something wrong with the DNA in the genes. Otherwise, it wouldn't be cancerous. So nobody was born with the abnormality. What happened is one of those cells, when they divide, they're supposed to make a perfect copy of itself. So when one cell divides and makes 2, it has to make a perfect copy here and a perfect copy there. Well, there's billions of nucleic acids that have to be done exactly correctly. And sometimes things go wrong. And what often goes wrong is a piece doesn't get carried over. So there's an absence of a piece of the chromosome. Or one piece that was supposed to be over here gets flopped over and switched with a piece that was on another area. And so there's this rearrangement of the genes in the DNA. And unfortunately, that can be a problem, because when some part gets rearranged, there's certain parts of the genes that are more active than others. So if you get a gene that's not supposed to be turned on, and it gets flopped over to an area of the gene where there's a lot of activity, now you have a gene that's supposed to not be turned on, and the protein that it's making is overexpressed. So there are certain genes or certain abnormalities that tend to be a little harder to treat and can, on average, make it carry a poor prognosis, and those are these 414 translocations, or if the piece of chromosome 14 is moved over to chromosome 16, or there's a deletion of this chromosome 17. So when those happen and those are present, that makes us more worried that the multiple myeloma will be a little more aggressive, and it also might, and I think it probably usually does, suggest we should use different drugs, because certain drugs work better with those, for the people with those abnormalities than others, like bortezomib. Okay. So what do you do to treat multiple myeloma? Well, obviously you want to slow the disease and frankly put people in remission, get rid of symptoms, and hopefully come up with some type of cure. And we can never kind of prove somebody's cured of multiple myeloma, because you can always say, well, maybe it's going to come back, and it can come back 10 years later, unfortunately. But hopefully, as we see more and more people 10 years and longer without it coming back, eventually we will be able to say some people are being cured, and I think that's happening now. Certainly, treatment is better than it was. It's always room for improvement. So until we get everybody in remission, cure everybody of this disease, there's a need for research and coming up with new medicines. But certainly compared to 10 years ago, we have more options, and more people do better and just live with multiple myeloma than ever before. There is no best treatment for multiple myeloma. So if you open a textbook, and I think even this has finally changed, but there's a disease that my mom still, I think, confuses with multiple myeloma called melanoma, which is the skin cancer. If you open a textbook and say, how do you treat multiple myeloma, the textbook will say the same drug that's been used since I was in med school. So for 30 years, the same drug. And frankly, if the drug worked great, that would be okay. But since it doesn't work great, that's bad. So there is a best treatment for melanoma, because it's the same. Everybody's able to figure out this is the drug, this is the only thing we got, this is where everybody should get. Fortunately, multiple myeloma, we have lots of new drugs, and by the time you figure out, well, it might be a little better to use these two drugs versus those two drugs, then there's a third drug, there's a new drug coming along, and now we have to do it all over again. And plus, people are different. The disease is different. How people have, what the multiple myeloma is itself, what's wrong with the cancer cells are different. And so you have to tailor the treatment for the disease. And then even when you start treatment, not everybody tolerates the therapy so well. Some people take steroids, causes no side effects. Other people take, half or even a quarter of those same steroids, can't sleep, their blood sugars go up to 300, and there's just no way they can tolerate it.
I know that by steroid.
Yeah, no, that's good.
You don't know what?
So how the types of treatments, usually we give combinations of therapies, and the reason we give a combination, it's because we can. That's almost the best answer, I think. It's just because you can figure out if one drug works and you're trying to injure a cell, it's better, it's kind of like a war, it's better to attack on 2 fronts or even 3 fronts than to use just one. If you can combine the two together. Now, we often do not do drugs that have the same side effects together, because if one drug lowers the blood counts and another drug lowers the blood counts, and you give them together, now you have, it may kill the myeloma a little bit better, but you also hurt the blood counts twice as much. And so you end up having to give less of each, which may in the end not work as well. So I think one of the first drugs that really changed compared to 20 years ago, 15 years ago, how people did with multiple myeloma was thalidomide. And it was used as a sleeping pill many, many years ago, and it caused, unfortunately, birth defects in the babies that were born of the mothers that took it. But that was why, actually, because of that, that was why the drug was used for multiple myeloma. So it turns out that the reason the baby's arm would not grow if the mother was on thalidomide is because the blood vessels would not grow when people were taking thalidomide. And if you're going to grow an arm, you have to grow blood vessels as the arm grows for the fetus. So in multiple myeloma patients, if you do a bone marrow biopsy on people with multiple myeloma, often you'll see a lot of extra blood vessels in there. And so it was thought by Dr. Barleby in Arkansas that, well, maybe we can do something to stop that, and maybe that'll help. And so the only drug available at the time for that was thalidomide, and so that's what was tried, and lo and behold, it worked for some people with multiple myeloma. Put some people completely in remission. I'm not sure that's the only reason. I don't even think that is the reason why thalidomide works. It has other actions. It kills myeloma cells directly, so if you take a culture of myeloma cells and put thalidomide in there, it will often kill the cells. It reduces some of the hormones that the myeloma cells need to grow, like interleukin-6. That's the main growth factor for multiple myeloma. So it was maybe by serendipity that it was discovered that it worked, but that's a lot of times how science works. You try something, you see, and it maybe makes some sense, and you get lucky, and now you have a whole new way of treating people. The next drug that came around is bortezomib. This is an extremely complicated slide, but basically it shows what happens in the cells normally and how bortezomib, what bortezomib does, it blocks the proteasome, which is the kind of garbage disposal for cells. So it blocks a hormone, it blocks an enzyme in the body, just like the Lipitor that I take every night blocks the enzyme that makes cholesterol. So you could, when people start taking these medicines, you can argue, is it chemotherapy? It's a chemical, it's therapy, but so is the Lipitor that I take at night. Thalidomide, bortezomib, lenalidomide, some of those, it's not like the classical chemotherapy drugs. And by doing that, by blocking that proteasome, it blocks this NF-kappa B and keeps it from migrating into the nucleus of the cell, and then that blocks a lot of hormones, cytokines, that the cell needs to survive. And just by chance, well, maybe not totally by chance, but plasma cells need that hormone, that proteasome, survive with that proteasome more than others. So you find something that will kill the myeloma cells that won't hurt other cells nearly as much. So people have looked at putting those together, and this was a study done in Italy where they compared the old treatment from 10 years ago, probably, I think about 10 years, maybe a little longer than that. If you were to ask most people with multiple myeloma what they were taking for treatment, it would be thalidomide and dexamethasone. So the Italians did a bigger study combining Velcade with thalidomide and dexamethasone. And in the light blue, you can see the responses to the thalidomide. So only about 12% of people went into remission with the thalidomide. But when the three drugs were given, 32% of people went in remission. These people went on to have a transplant. And even after the transplant, 23% of the people that only had thalidomide went into remission. 43% who had the Velcade with it were in remission. And a very good partial response, a 90% improvement in the antibody protein. So you presumably kill 90% of the myeloma cells. Again, it was higher for the three drugs. Now, bortezomib has, unfortunately, a side effect that we have to all watch for, and it's really important for patients to work with their doctors with this, and that's that it causes neuropathy, and it can come on pretty suddenly. So it's important when somebody's taking Velcade that you take notice of how your legs and feet are working and feeling, because if things you're starting to have symptoms, you can let the doctor know, and the dose of the medicine can be adjusted downward so that you don't end up with neuropathy. That can be permanent, but it often does improve with time. So recently, there's a new way of giving Velcade. So most people that took it a year ago were getting it in their vein. That's intravenous, in the vein. And that's the way the drug was approved initially, and that's how we all gave it. And then, really for convenience sake, it was decided, well, maybe, some people don't have such great veins, maybe we can do it as a shot. And I think I was even approached to do this study years ago, but for a while they were having a hard time at Cedars to do studies. So this was a particular study with a shot of Velcade versus the intravenous way of giving Velcade through the vein. And basically what happened is that nerve injury or neuropathy was less if you took it as a shot. Didn't go to zero, so it's not like you take the shot and I won't have neuropathy. But you can see down here the more severe neuropathy went from 16% of people down to 6% of people. So certainly an improvement. When you give it as a shot, it can cause a little bit of redness where the shot is given. And that can linger for a week or two. Doesn't seem to be anything dangerous about it, but that's something of a trade-off is the injection site that gets kind of irritated. So more and more, and I would say the majority of the patients that I take care of now, you get the Velcade as a shot. So the next drug to come around is lenalidomide, or Revlimid. for all those who are good chemists, on the left there is the chemical structure of thalidomide, and on the right is the chemical structure for lenalidomide. There's not a huge difference, yet just that kind of minor change made it a lot more potent in certain areas, like inhibiting one of the hormones called TNF. That may or may not be important, but it did change some of the effectiveness of the drug. And really the study that was most important for this drug with Revlimid was this one. This was done throughout the country, and they gave people Revlimid with dexamethasone. These are brand newly diagnosed patients, so people that just found out they had multiple myeloma, and then they got offered either Revlimid with dexamethasone, the 40 milligrams, 4 days in a row, and 4 days without it, and 4 days in a row, and 4 days without it, and 4 days in a row. So 12 days every month of dexamethasone versus not really a low dose, but less frequent dexamethasone, once a week dexamethasone. And people took it for 4 months and then decided what to do thereafter. And what was found with this study was, while these people responded a little bit better, these people responded almost as well, but they had a lot less side effects, as probably people who've taken dexamethasone could attest. So they had less pneumonia, they had less blood clots, and ultimately that, if you have less side effects, especially serious side effects, you actually live better, live longer, and that's what was found. These people were more likely to be alive 2 years later than the people on the top. So then the question is, well, what happens after you do those 4 months of treatment? What happens to people based on what they did? So some people on the left took 4 months of treatment and then just stopped treatment. Some of them were feeling well, their disease was in remission, or their pain was gone, or maybe some it wasn't really working, so they stopped. Other people took 4 months of treatment and then decided to have a stem cell transplant. And then finally on the right, some people, kind of the majority of the people, just stayed on Revlimid and dexamethasone. And the people that did the worst were the people that stopped. So they had, I didn't show the curves up there, but they had the worst survival. And I think that's going to be kind of my mantra for today, is that, you know, stopping treatment, while necessary sometimes, often will allow the disease to progress. And sometimes you can't catch it when it progresses and control it again like you did when you had it beaten down. The people that stayed on treatment did pretty well for multiple myeloma patients, and then the people that had the transplant did the best, and that's kind of one argument I would show you in favor of doing transplants, is that it, you know, in general improves patient survival overall, although admittedly there are quite a lot of people doing well that never had the transplant. There is an interesting study, and I'm going to show this, but I don't think we're just so, I don't know if there's anybody with like smoldering myeloma in the room. So this was a study done in Europe, and right now the treatment for smoldering myeloma is maybe something to protect the bones, but no active, anti-myeloma treatment like Revlimid or Velcade or steroids. So the Italians looked at that. They compared, or maybe it was Spanish, I don't know, I forget. One of those two. Revlimid and Decadron versus observation. And clearly on the left it looks great, because if you give somebody treatment, particularly a reasonably good treatment, you're not going to progress as well. Versus in blue, if you just do nothing, people will more likely have the disease grow. That's kind of an unfair comparison, really, because you're giving something versus not giving something. These people in blue, you can then just, when it progresses, start them on treatment. The key is, does it translate into, do you lose some people by waiting, basically, to be blunt? If you wait till the disease progresses and then treat them, are people more likely to die with multiple myeloma? And there's a hint that that might be the case. But so far we can't say with certainty, and we're just every year getting an update on what happens to these patients. Now, if you can use two drugs like Velcade and dexamethasone, or Revlimid and dexamethasone to treat the multiple myeloma, boy, what about using all, three of them, Velcade and Revlimid and dexamethasone, kind of all three at once. And when you use all three at once, way at the bottom, you can see PR means for a response, partial response. 98% of people with newly diagnosed disease responded to the treatment. So almost everyone will respond if you use all three of the drugs. And so when you start combining things, the response rate goes up, although some side effects go up too, because now you're dealing with side effects from 3 medicines instead of 2. And it's not totally clear how, is it worth the extra side effects or not, although many people, this is what they're using. Or Velcade, dexamethasone, and Cytoxan, a chemotherapy drug. So I'm going to talk about transplants. There's 2 types of transplants. They're very different. They're an important distinction. One is an autologous transplant. I don't know where the wording comes from, but it's using your own. So you collect your own stem cells and use them as the transplant. Or an allogeneic, which is where you use some other person, often a brother or sister, but you can use somebody throughout the world who happens to have a white blood cell match to your own. So what happens when you have a transplant? Well, first you have to get, generally speaking, you'd like to get the cancer controlled, because you're going to be collecting your own stem cells. And I showed years ago that if you collect stem cells right at the beginning, right at diagnosis, or when the disease was not controlled, it's full of myeloma in there. So you'll be collecting a lot of the myeloma cells as well as the good, healthy stem cells. So usually when people do a transplant, you give some type of initial treatment to debulk the cancer, make the cancer, in remission or getting there. It doesn't have to be in remission, but at least better controlled. And then the cells that regrow the bone marrow are normally in the bone marrow. It wasn't until about 20 years ago that people even knew you could find those cells in the blood. So obviously, if we didn't know until 20 years ago you can find those stem cells in the blood, there can't be very many of them floating around in my bloodstream right now. So we have to coax them out in order to collect them, because back in the old days, when I was at UCLA, we would collect it from the bone marrow, but that's where the myeloma is. And then just collecting it from the bone marrow is not a very fun thing to do for people. So we would mobilize, kind of collect the stem cells and get them out of the bone marrow into the blood. And in order to do that, there's some shots that are given. It's like a stimulant, Neupogen, along with a lot of times chemotherapy, because when your body recovers from chemotherapy, it sends out the seeds, it sends out the stem cells into the bloodstream. And then once they're out there and the blood's recovering from the chemotherapy, that's when we collect the stem cells, and then we can store those stem cells for the future. And once stored, they're good, presumably forever. I've used stem cells on people that have been stored for 10 years, and they did just fine. And then the treatment with a transplant is the chemotherapy. So you give a big dose of chemotherapy that indiscriminately kills bone marrow cells. And then when the chemotherapy is out of the body, which happens in a day, and the poison's gone, then you take those stem cells and put them back in, the ones you were in a tank and never saw the chemotherapy, and that will regrow the new bone marrow in a week and a half or 2 weeks. So that's the concept. But obviously the side effects are, maybe not obviously, but it's a big dose of chemotherapy. So it makes people sick. You get a big dose, you get 10 times, 20 times the amount that you normally would take of chemotherapy. In this case, melphalan. It's going to cause some other side effects. And that's why people generally stay in the hospital to kind of help them through that period until their blood counts recover. And the question is, what do you do after that to keep people in remission? Now, there has been a study, and it was actually mainly overseen by Dr. Krishnan, who's one of the doctors, a very good doctor at City of Hope, looked at what about using a brother or sister as a transplanted, as the donor. Maybe that's better in the long run to do. So in this study, it was a big study done throughout the country. People with multiple myeloma had one regular old transplant with melphalan, and then 2 to 4 months later, they went and either had another transplant or they had a brother or sister. If they had a brother or sister that matched, they had an allogeneic transplant. So it was a way of this, and then you saw who did better. The people that had a brother or sister's transplant as the second one versus people that just had a regular second autologous transplant. And the bottom line is it was not better to have the brother or sister transplant, the allogeneic transplant. The survival was about the same. And I would say even if the survival was a tiny bit better, I don't think I would suggest doing the allogeneic transplant because it's a lot harder on people. I mean, people can get sick even when the transplant's done. So we generally don't do those allogeneic transplants unless we're kind of running out of other things to do and for patients. So we tend to do it at Cedars-Sinai more as a last, I don't want to say last ditch effort, but kind of when all else has failed, because then at that point it's maybe worth the risk of the procedure. So multiple myeloma is hard to cure. People maybe argue whether you can or not. But you can often control it. I mean, again, my cholesterol's high, and I had some problems with my heart years ago. So I'm not cured of that condition. So I take medicine to hopefully keep me from going into the hospital again. So I think it's the same with multiple myeloma. Is you have to. I think often it's helpful to take medicine to keep the disease controlled. Dr. Berenson did a study years ago looking at just steroids. In this case, it was prednisone, taking it every other day after chemotherapy. 20 years ago, we used this chemotherapy regimen called VAD, or 2 chemotherapy drugs called vincristine and adriamycin, and then steroids, prednisone. And so some people, once they had the chemo and felt well, they just stopped, and you just watched and kept your fingers crossed. Other people took steroids. The other half people took prednisone to try to keep the multiple myeloma from going back. And the people that took prednisone lived longer. If you took Revlimid versus nothing. The Italians do something similar to what I often suggest. Revlimid, 3/4 of the people, 73% of people are in remission with their multiple myeloma, which is a lot higher than you see with any other type of initial treatment. So what about if somebody is not eligible to have a transplant? This was a study that was just reported in the New England Journal of Medicine. That's really the most prestigious medical journal in the world, is the New England Journal of Medicine. So the big important studies go in there. This was where they looked at Revlimid and melphalan and prednisone. My bias right off the bat here is I don't really like this regimen, mainly because melphalan can cause some problems with time, and frankly, Revlimid's main side effect is to lower the blood counts. Melphalan's main side effect is to lower the blood counts. Revlimid's main side effect maybe there is a worry about it causing leukemia. Melphalan's worry is they can cause leukemia. So to me, I just don't particularly like this rough regimen cocktail. But what it did show is that if you stop treatment after just 9 months, that people really didn't do as well, that their disease quickly progressed. You needed to stay on some type of treatment, and they did better that way. And this is just my view on keeping people on treatment, is when you're in remission, that's not the same as being cured. Remission means there's not enough myeloma to find. So, if we come up with a better test, maybe we can find, 10,000 myeloma cells in the body. But right now, it takes millions, actually hundreds of millions of myeloma cells to be around before we can find them in the blood test, and even on the bone marrow biopsy. Just to put a number to it, it's a kind of a scary number, but that's the reality of it all. When people find out they have multiple myeloma, it's hundreds of billions of the myeloma cells. Studies almost always show that if you stop treatment, you're more likely to relapse, but less likely to have side effects, obviously. But that can shorten survival. And sometimes, and what gets people in trouble is when more times it comes back, the cells that come back were the ones that lived through the previous things it was exposed to, and they can be just more aggressive. So everybody has their bias. I know many of you know, like for example, Dr. Berenson, he's not a big fan of doing transplants. We all have our little bias, and it's just my way of interpreting things and what I've seen through the years. But I just think people, if you can tolerate something, should stay on treatment. Now, let me talk about trials, and then we'll stop for lunch. Trials are important because that's how we figure things out. That's how you can find out if there's a new drug. That's how you can see if you do the old way versus a new way. The new way might actually be better. Sometimes you get surprised when you think sometimes a new treatment's better, and in reality had nothing to do with it. So trials are made up into three phases. Phase one is that when a drug first becomes available for study. So you have a drug that looks promising in cultures or in animal models. And so the first thing you have to do when you first give it to that first person is you have to make sure it's safe. You don't know what dose to use. I mean, you know what dose to use in a mouse, but people aren't mice, so you have to figure out what to use in people. So you start off with a very low dose and work your way up and until either the drug works or until people start having side effects. And then you say, whoops, that's a little much. Now we got to back off. And then that's how you find out what dose to use. Phase 2 study is now that you know what dose to use, now let's see if it works. And so that's how most of the studies are. A lot of studies are phase 2. It's like, well, this looks promising. We know the dose. Now let's test it. And then phase 3 is, well, we have a drug. Looks like it works. Is it better than what we already have? Because just because you have something that works doesn't mean you'd want to use it in favor of things that we already know are effective, like Velcade and Revlimid and things like that, steroids. So the new drugs I'm going to talk about, really the first three. Carfilzomib is probably the first one to talk about. So that was looked at in patients with relapse disease, and it did have some activity, even some people that had a lot of prior treatment, and it seemed to cause less nerve damage, less neuropathy. So just as an example of a study, this is a study that's being done where they combine carfilzomib and Revlimid and dexamethasone. So all three drugs, and these are brand newly diagnosed patients. So if you take people who've never had any treatment before and you give three different drugs, all working a different way, it's probably going to work pretty well. And it did. The way carfilzomib is given is it's given through the vein. You can't give it as a shot. And it's given 2 days in a row, like Monday, Tuesday, Monday, Tuesday, Monday, Tuesday. And with that, the reason it's kind of exciting is that basically with those three drugs, everybody responded. Although that's kind of what we got with Velcade, Revlimid, and dexamethasone. It is like Velcade, like bortezomib, it blocks the proteasome. It seems to have activity about the same as Velcade. It may be a little stronger, may not be in others. The thing that makes it a little advantageous is that it causes less neuropathy, or at least it appears to. And we have, I guess next week again, it'll be available for us to give as part of a study. Hopefully it's going to be approved in any case in the next few months, and we're just waiting for the FDA to decide one way or the other. Another drug that looks particularly promising, to my knowledge doesn't have a name yet, so it's just got a number, MLN9708. And that's a pill, so that's why the whole Senate thing is important for people to kind of have the payments better for oral medications. This one does the same thing as bortezomib, but it's taken as a pill. It doesn't seem to cause so much neuropathy, so it seems also to be much easier on the nerves, and it looks like it works. And so, as an example, this was a study that this is an old slide a little bit, unfortunately, but we had this study open. It's now closed because they only needed 50 people in the whole country. So obviously, that's not too many patients. But it was given with Revlimid and dexamethasone in people newly diagnosed with multiple myeloma, and again, everybody had a response. And it seems in the patients I've seen taking it be well tolerated, no neuropathy so far. And then there's the other drug that hopefully will be available by the end of the year. It's called pomalidomide. And this particular study was for people who no longer were responding to both Revlimid and Velcade. So your Revlimid's not working, Velcade's not working, and then they went on to this study with pomalidomide and steroids. And about 40% of people responded to the pomalidomide and the dexamethasone. Now you can't compare numbers because these people, it's harder to treat these people in general. These people already have drugs that don't work, whereas when somebody's just diagnosed, everything might work. And it seems to be pretty well tolerated. I've given it to a few people, and they don't seem to have they seem to have less side effects than with Revlimid and thalidomide. But, I don't have so much experience with it. It was, just to kind of give you an example, it was combined with other drugs like Cytoxan and prednisone, and had some pretty high response rates. 65% of people responded, 7% of people went into remission. So people will start combining it with other drugs in the near future, and particularly if and when it gets approved, hopefully in the next 6 months. This is just to show you that sometimes drugs look promising, and then when you try them, it doesn't really work out so well. So this was a huge study with a drug called Verinostat that's actually available to treat lymphoma. And it was given with Velcade, or Velcade was given by itself. So either you took the new drug with Velcade or Velcade by itself. And really there was no difference in survival. and the time in progression was really not better. So I don't think, unfortunately, despite it working in culture plates, this one's probably not going to make it into the clinic. There's a couple other new drugs that look promising. This is another oral drug, so a pill, and it blocks another enzyme that's important for myeloma cell growth. Not huge response rates, and it was given with Velcade, so it's hard to say how much was the Velcade, how much was the new drug, but there's been some activity. This is Dr. Rubin from the Mayo Clinic in Arizona. And then there's an antibody. So in lymphoma, there's a drug called Rituxan, which is a great drug because it sticks to the lymphoma cells and then your own body destroys the lymphoma cells. So it would be wonderful to have such a thing for my own patients because Rituxan, unless you have an allergic reaction to it, it is pretty side effect free. These antibodies are well tolerated. This particular antibody is to CD138. That's a protein that's usually found on myeloma cells. Unfortunately, it's also found on some skin cells, and so that's why some of the people did actually have side effects, like hand-foot syndrome. Sounds weird, but you get like redness of the hands and feet. And just with the one drug by itself, some people responded. Not a lot, but at least some people did. And then here's just another one that's out there that's being tested. This blocks part of the mechanism which cells use to divide. And so cancer cells, since they divide more, blocking that can often be more toxic. And again, they've had some side effects, they've had some responses as well. So there's drugs out there, there's probably 10 more I could list of new drugs being tested. Some look more promising than others. So the thing, just the last couple slides, the things that I think are important is you have to, it's not just the doctor taking care of you, you have to be your own advocate. Because as an example, things like, I'll give you two examples. One is with thalidomide. I had a gentleman taking thalidomide for many years, and he would come to see me and ask him how he's doing. His labs look good, and he'd say, fine. Okay, see you next month. So then all of a sudden, one day after a few years, his family comes in, his kids, and they say, Dad's not the same. He's not really, he just isn't the same guy as he was a couple of years ago. And I go, well, what's wrong? Well, he's a little, he's afraid to drive long distances. He seems to gets lost at times. He seems he's just not as sharp as he used to be. He's a little tired. He's just not the same dad. And so now that I heard that, that sounds like thalidomide is causing some side effects. So let's take a break. Let's see what happens. And sure enough, a month later, he comes in with his family, and everybody's smiling. And Dad's back. He's alive and well. He's driving the car. He has more energy. But he never. All I got every year for 2 years was, yeah, I'm fine, no problems, I'm doing okay. So you need to mention those things because maybe there's a fix. He happens to be on Revlimid now, and it doesn't bother him as much. It can cause anemia, so that's not the myeloma can do it, but a lot of times the drugs can do it. It can cause blood clots, and so if that's a symptom that you have a blood clot, it's a painful or swollen calf. If you don't mention it to the doctor, then there's no way we can find it and prove that it's there and then fix it. Kidney damage. So myeloma cells make a protein that can harm the kidneys. So if you get dehydrated and the myeloma is active, then your kidneys can be harmed, sometimes irreversibly. It's not getting better. So it's important to not get dehydrated. There's a limit. I don't advocate people drinking 3 gallons of water because actually that can cause problems too. Moderation, but definitely have enough fluid so you don't get dehydrated. Infections. I'll just give you a bad story. I hate to do this, but I think it's educational. I remember seeing a lady who everything was well, and she was, well, I can give two examples. A lady when I was at UCLA who was getting ready for a transplant, and I was about ready to collect her stem cells, and she's at home, apparently, and all of a sudden she calls, like on a Sunday, after being sick with a fever for 2 days. But she didn't want to bug me because it's Friday night. She's a nurse. She actually took care of one of my other patients. And so she just didn't want to wake me up. Figured she'd wake me up Friday and didn't call me Saturday because, hey, it's Saturday and, I shouldn't be working on Saturday. So then Sunday, 911 was called. And then she was brought in the hospital and it was too late. She died of, the infection. So, I'll never forget her, and that's terrible because usually we have antibiotics to pretty much fix other than Ebola virus, pretty much every infection we can fix. It's just getting it in there in time. Neuropathy, there's no blood test for neuropathy. So if blood test can look perfect, if you don't mention you're having it, I won't know that you're having it. So you have to describe what's happening, and that way, you can weigh the pros and cons on what to do. Osteonecrosis, that's this infection of the jaw, and that can certainly happen in people that are on Iridia or Zometa. The big thing is to take good care of your teeth, because, I think those Iridia and Zometa are helpful, but they can have this as a side effect. And then if you have pain, we actually do have procedures that sometimes can fix that, called a kyphoplasty. So that's it. I'll stop there and let you guys go to lunch and then answer questions.
Okay, thank you, Dr. Vescio. So we'll get to questions later after we start eating lunch. So right now, let's take a little break, and the lunches are back there. So go ahead, enjoy yourself.